Hello guys, Dr. Qureshi here, and I was going to talk about something that I'm seeing on a regular basis in pretty much all the clinics that I'm working in with Thurman Eye Associates and Ascend Vision Partners. So we are covering clinics or seeing patients in McAllen, Edinburgh, Mission, Harlingen, Weslaco, all these areas. Our surgery center is in McAllen, and then the patients are seen in all the other clinics in all the places that I just mentioned. So one thing that I wanted to tell you guys is McAllen is known to have the highest rate of diabetic patients in the entire state of Texas, and that's humongous because, as you already know, Texas is a very big state. I think it's number 3, I guess, as far as area is concerned. And then definitely to have the highest rate or highest number of diabetic patients in a particular city in the entire compared to the entire state is significant. So you guys need to be careful about your diabetes and a good diabetes control. So today's video is going to be focused on that because I am seeing patients all the time. They have the triad of diseases, as we call it, which includes diabetes, hypertension, and high cholesterol. It's also known as the metabolic syndrome because all these 3 diseases are included in that category. So my patients have been asking me how to maintain their blood sugar levels at a normal range, and I always tell them diet, exercise, and medications go hand in hand, and then we have the discussion about genetic part versus what they can do to improve their lifestyle. So again, the nature versus nurture whole debate starts, and then they ask me for tips on what to eat and what kind of exercises to do. And as you recall, there is a video that I did about like a few months ago where I talked about having a good lifestyle and focusing more on preventative medicine, which means preventing diseases from happening with a diet control or healthy lifestyle and healthy eating, and also exercising. So it's just a matter of discipline. It's just a matter of doing things repeatedly so that it becomes second nature for you, and then you can just maintain that lifestyle for the longest time. So some of the things that I wanted to talk about, especially from the perspective of what the patients have been asking me in the exam rooms, literally every day I'm seeing diabetic retinopathy. Every day there will be a major number of patients who will have diabetic retinopathy. And if you recall from my previous videos, diabetic retinopathy can be non-proliferative or proliferative. Non-proliferative is the milder form. I'm just going to explain to you in very, very easy terms today. So the non-proliferative would be mild, moderate, or severe, and then again proliferative would be mild, moderate, and severe. They can appear with macular edema, which obviously decreases the vision more so, or without macular edema. So one particular case that I wanted to talk about is a guy who came in to see me for the first time, and he had never seen a primary care doctor. He had never seen any eye doctor or eye specialist in his entire life. So imagine. So he comes in, and he had loss in vision in one eye. So he was blind in that eye. It was sudden onset, unilateral, painless vision loss. And when I was examining his eyes, I obviously had to dilate him. And I was like, okay, what is going on? So does he have hypertension? He didn't know. Does he have diabetes? He doesn't know because he's never been to a doctor before in his entire life. So I was very concerned, dilated him, did a lot of tests on him. He had macular edema, he had macular hemorrhages, he had diffuse proliferative, like severe diabetic retinopathy, proliferative with macular edema, and on top of that, he had cataract. So the cornea, or actually the lens, and then the cornea had some edema also. So I'm like, it doesn't fit the typical picture of having a severe diabetic retinopathy with macular edema. So it has to be something else, and it was unilateral sudden onset of loss in vision. So again, recall from my previous videos where I talked about central retinal artery or branch retinal artery occlusion. Remember, I don't know if you guys can remember or not, or central retinal vein or branch retinal vein occlusion. So I was thinking, okay, it has to be one of those. But then the picture was not classic. It looked kind of diabetic retinopathy, and then it looked like a central retinal artery occlusion also. So I was very concerned for this patient and I wanted to send him to our retina specialist. We do have a very good retina specialist in our practice who covers literally all the patients with diabetic retinopathy or any retinal complications. So I discussed the case with him. Luckily, he was working in the same clinic where I was that day. And I said, you know what, it seems like it's not diabetic retinopathy. It seems more like, or it could be a component of both. Like he had long-standing diabetic retinopathy because the bleeding, from what I recall, was happening in both eyes and the macula looked significantly worse in one eye than the other. Now remember, the hemorrhages for central retinal the hemorrhages for diabetic retinopathy are very significant. Like they will be macro or microaneurysms or dot blot hemes, and then the macular edema looks very classic, and you can definitely confirm that with the macular OCT. But in his case, it was very difficult to get a good view because I also saw some kind like borderline retinal detachment or retinal tear definitely happening. And then I also saw the retina that looked classic for a central retinal artery occlusion. So of course, the retina for a central retinal artery occlusion is going to look different than diffuse hemorrhages that happen in diabetic retinopathy. So it was a complicated case, and what I was trying to explain to the patient is that you could have prevented all of this from happening if you had started going to your doctor for a routine dilated eye exam. That's it, like, you know, or going to your primary care doctor to get your blood tests done, to get your A1C levels checked if you had diabetes, or at least getting a CMP, complete metabolic profile done, so that your PCP could have treated you or guided you to come and see us also, so that you never ended up having eye conditions. And then the patient never showed up for his appointment with the retina specialist. So these are the things that we have to be careful about, because when I asked the retina doctor who is in our practice and I discussed the case with him, and he said, sure, I'm going to see him first thing in the morning. But then a few days later, when I met him again, I said, hey, what happened? Was it a CRAL? Was it a central retinal artery occlusion? And also one more thing that I noticed in that case was that his pressure was really high in the eyes. And maybe because of that, there was significant corneal edema. And therefore, I wasn't getting a very clear picture of the retina at that point. So, and then we both decided that, yes, it has to be a CRAO or central retinal vein or artery occlusion. The vein occlusion can also obviously present with hemorrhages, but they look very different than a diabetic retinopathy. But anyhow, because of the fact that his pressure was so high, it was really high pressure. I can't remember the exact numbers, but it was really high, and I had to give him acetazolamide, the diuretic pill. I had to put him on all kinds of glaucoma drops in order to bring his pressure down. But we were thinking, if the pressure is high, then it has to be one of those conditions like CRAO or CRVO or branch retinal artery or vein occlusion. But in retinal detachment, I don't think it was a retinal detachment. I think it was just a vitreous hemorrhage is what I'm thinking, because in retinal detachment, the pressure or intraocular pressure is going to go down. So anyhow, after discussing all of this with the doctor and him being nice enough to see him the first thing in the morning on the following day, the retina specialist told me the patient never came for his appointment. So these are the things that are very, very, how should I say, not frustrating, but very weird, because like you wake up one day, God forbid, and you lose your vision. He was legally blind. He was seeing as far as he can recall, he was seeing fine, and then one fine day he just lost his vision. So this whole video is about diabetic retinopathy and how to prevent all these things from happening. But sometimes with diabetic retinopathy, which is long-standing, you can also have other conditions. So most likely this patient had a combination of both, like diabetic retinopathy, which didn't cause loss in vision suddenly, but with a component of central retinal artery or vein occlusion. So because of all of these things, I always like to remind my patients the timing is very important. You guys have to come back for your follow-up appointments. You just can't just come one day for emergency eye visit, which we happily do see patients for. For instance, this patient did come in emergency and we did take him in right away. But after doing so many tests and trying to help him and trying to coordinate his appointment to come back and see us so that something could be done, whether it needed an injection in the retina or it involved sending him back to his PCP or finding him a PCP or sending him for emergency endarterectomy or carotid Doppler ultrasound first. Like there are so many things that could have been done involving a neurologist, involving a retina specialist, and all of those things were explained in detail to the patient, but he decided not to come. And I can understand there could be family emergencies that happen, or something must have happened to the patient that prevented him from coming back. But I mean, with at least a phone call could have been made or something along those lines. So I feel like there's so much that can be done in preventing these things from happening. And again, we go back to the point that I've been trying to make for the longest time. If you do not come for a routine checkup or routine exam, there will be nothing that can be done that can prevent these things from happening. And the most important thing is to find a good doctor, to find a PCP so that they can send you to us. And we do get a lot of referrals from endocrinologists and primary care doctors, like family doctors and internists. That's good. That's really good. We all need to work as a team. And that's another thing I wanted to talk about, like, working as a team. Every subspecialty needs to work together so that at the end of the day we can help the patients. And I feel like because there's so much diabetes in McAllen, Edinburgh area, or we call it the Rio Grande Valley area, there's so much that we can do through community networking, public messages that we can provide to the patients, or me as in a doctor, because my patients have been telling me that, doctor, because of your YouTube channel you can reach a lot of patients and a lot of audience, so please start telling us about a good lifestyle. So again, back to the good lifestyle, I tell my patients, just try to eat the Mediterranean diet that I've talked about. That's the best diet for your health, for your eye health and your systemic health. And if you want to know some tips about what a Mediterranean diet is, you can go you can go to the video that I have posted recently, which includes all the basic components of what a Mediterranean diet includes or involves. So that's one thing. And then also walking is a good exercise. Even if you want to do 30 minutes walking every day or at least 5 days a week, that's very good for you. Getting your regular checkups done, eating healthy, eating right, and doing intermittent fasting is very good for your general health. And discuss these things with your primary care doctor also, because they are the ones who can give you a lot of information, because that's what they do for a living. They treat diabetes and hypertension and high cholesterol. So guys, think about all these things. And if you come to us and you do not have a primary care doctor, and I'm the first one to find bleeding happening in your eyes, and then I say to you, hey, do you have a primary care doctor? Because we technically are supposed to send a letter, which is known as a diabetic report, to your primary care doctor, which we do in every case, in every patient. That's how their primary care doctors get to know the severity of the disease, and then they can adjust the dosage of insulin or metformin or whatever they're taking for that matter. But if I'm the first one to see bleeding happening or diabetic retinopathy happening in your eyes, and then I say, okay, well, you need to have a primary care doctor, get a primary care doctor. That's the whole purpose that I am telling you to get a primary care doctor, because I'm not going to treat your diabetes. I'm going to treat your eye diseases, but as a disease, as in having diabetes, that should be treated by your primary care doctor or endocrinologist. So that's what I'm trying to educate the patients about, to go for your yearly checkups and also listen to your doctors. And if you want me to make videos on particular topics or certain things that are important to you as far as eye diseases are concerned, just let me know. You can send a message in the comment section, and I will definitely try to follow up on that. Okay guys, take care of yourself, take care of your health in general. Thank you. Bye-bye.